Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EZ-Flow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EZ-Flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. This is just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
That's a good picture, John. And hello, good evening, everyone. How's everything going? Welcome to Perf Web 47 and the Tammy Sparacino Journal Club number 10. I'm joined here today in the studio, of course, with Tammy. You see her now. And then coming in via our Skype channel will be John Ingram coming from Orlando, Florida. A couple of things I need to go through the housekeeping notes, if you would, please. Visit our sponsors, LivaNova, Siemens, and Houston Extracorporeal Technologies. We appreciate these companies' support of these programs that we do. And if you're a company out there watching this, or you know somebody in industry that may want to also advertise on our channel, please send them my way. It would be greatly appreciated. Social media, please make sure to like, follow, and share us on the Facebook, the Twitter, the LinkedIn, and the YouTube channel. Make sure you click the subscribe button, give us the thumbs up for today's program and for everything, and also use the bell notification key or button so that you can be notified when we do special programs. We're going to do another one of those wine programs like we did last week on Saturday. It was so absolutely well attended. It's amazing to me. I don't know, I'm not sure. I know there aren't that many perfusionists in the world, so I think we had some non-perfusionists watching it, but wine is apparently a very big topic. Okay, websites. Please reach out to us at perfweb.us, perfusioneducation.com. Perfweb.us is really more of our schedule for these live events that we do. Perfusioneducation.com is our library. We just got through adding, approved, by the way, for Category 1 SDCE. Now, keep in mind, you can only claim 10, right? You can only claim 10 per 3-year cycle. But, you know, we want people to have, you know, an option of what they want to watch and not just anything. So we just got through getting approved and posting on our Perfusion Education channel 116 hours of SDCE, Category 1 SDCE. So I'm really happy with that. You know, the number of videos, the number of programs, the number of topics in our channel just keeps expanding.
Keeps growing.
And, yes. And our internal registrations, people who are subscribing to our internal site, which is perfusioneducation.com, it continues to grow. I mean, so we're really, really proud of that. Contact at perfusioneducation.com if you would like to maybe join our faculty. You have a a request for a particular topic you would like to see discussed here on this program, we're certainly willing to do that. If you'd like to be a part of our faculty, contact at perfusioneducation.com. I will get that email and I will respond to every email that I get. Our call-in number, when you see this symbol, phone lines are open, 832-239-5358. You can call, be live on the air. I wish people would take more advantage of that. They don't like to, but I would love for it to happen today because this is a great topic, right? This is a very, very interesting topic I think we're about to do right now. Our new MediWeb app, if you have not already done so. Now look, there's two apps. One is the critical care application for perfusion, but it's also very germane, applicable, maybe would be a more appropriate term, to the ECMO specialist. It's for critical care nurses. It'd be good for critical care docs. It's a very comprehensive app, and it's only $2.99. Now there's a mini app, which is an IV drug and dose. Can you go back to that? IV dosage and rate calculator, which is a standalone app for critical care nurses, which I think has great utility. That one's only 99 cents, but that is also incorporated in the critical care app, which has a perfusion quick calcs for your flows, BSA, heparin dose, protamine dose, your predicted hematocrit post-dilution, the whole 9 yards, and a lot of hemodynamic measurements as well that you can derive from the calculations. So it's $2.99. I need to sell about 1 million of them so that I can finally retire. So, you know, and I got to sell 1 million one at a time. So please, somebody go and buy my app today. Appreciate that very much. And I think that is it. The topic today is SARS-CoV-2 or COVID-19 pandemic, referred to in quotes as coronawar. Something was forgotten. Cardiovascular, oops. Yes, I forgot the oops. Cardiovascular disease is still here. And what has been the collateral damage? With that said, Tammy Sparacino, the floor is yours.
Thank you. Good evening, everyone. Thank you for joining us for this discussion. So this particular article is actually an editorial, but I liked the subject matter so much, I thought it would make a really interesting discussion, topic, point, jumping off place, the way we normally use these articles. This particular article was published in July 11th, 2020 in the Journal of Cardiovascular Surgery by Papa Constantino. Sorry if that's your name.
That's pretty good.
Trying real hard. And Associates. And let's go ahead and get into it.
It must be an Irish name.
I think it's Greek.
Maybe so.
Okay, why was this paper published? The significance of the article. Well, it was an editorial opinion, and the authors had the opinion that the healthcare system has been monopolized by COVID-19 preparation and planning, and they wanted to know what the impact on cardiac surgery patients has been thus far through July when it was published. Okay, how did they go about assessing this? Well, they used several examples, and they started with case report. This is a 48-year-old male, had a VSD post-STEMI. Third day of chest pain is when he decided to visit the hospital because he was afraid. He was afraid of what all the possibility of getting infected with COVID, so he stayed at home. By the time he came in, he was in critical condition. Now, he did have a successful but delayed surgical treatment. Case report number 2. 67-year-old male had dyspnea, suspected COVID-19 infection. You'll notice I said suspected. Became hemodynamically unstable. They then determined did not have COVID, had an acute ischemic mitral regurg, significant delay to diagnosis, but he did have a successful surgery.
That's pretty lucky.
Yes.
Because you blow out a septum or a papillary muscle, you usually don't survive that.
Exactly. All right, case report number 3. 59-year-old male, dyspnea, fever, suspected COVID-19 infection. It's later determined that they had acute aortic regurgitation due to endocarditis. There was a 5-day delay to surgery until they got that diagnosis, and then it was under emergent conditions. Successful surgery. Case report number 4. Suspected COVID again, later diagnosed with an acute aortic dissection, was then transferred, once they figured that out, to the appropriate hospital for the surgery, but died in the ER. It was too late. Overall, there was a delayed surgical treatment trend. Some of the reports that they followed, Austria reported 40% decline in MI patients seeking treatment. Hong Kong reported significant delays in the treatment for STEMI patients. Northern California hospitals, and these were big hospitals. I believe it was 5 hospitals in the Northern California area. 48% decline in hospitalizations for acute coronary syndrome. Northern Italy, similar to Northern California, much less hospitalizations. And this is, we're talking just since March through, just before this article was published. One study in the U.S. reported a 38% decline in STEMI treatments from 9 major hospitals. Spain noted a 40% reduction in STEMI treatments.
So pretty consistent in the percentages.
Right. So it didn't really matter where it happened. At these larger facilities, they were seeing delayed surgical treatment. Okay, so actually, before we get to the conclusions, let's just talk about this. Why do we think this was happening? Well, the authors note that patients were likely afraid of being infected, so they deferred their treatment. They some patients were even quoted as to saying that they would rather stay home and have a heart attack than go into the hospital with the possibility of getting COVID. That's how much fear was out there. Many places had stay-at-home policies, and a lot of the elderly people were doing that. They were staying at home. Medical therapy was being substituted for surgical intervention. Now, that was on a practitioner level, and also perhaps the lack of blood, because with stay at home and also fear going on, donors aren't going out to give the blood, so therefore surgeries weren't able to take place in the normal manner that they had. So let's get to some conclusions. The authors concluded that cardiac surgery patients became collateral damage from the collateral damage during the pandemic. COVID-19 is a new hazard but doesn't replace previous hazards. Heart attacks are still happening, and therefore cardiac surgery still has to happen. All right, we can open up the panel. Do you have anything you want to say about this particular article before we get into the big topic we're going to talk about today?
I mean, so many things, but I think maybe reserve it.
Do you want to hold till the end?
Yeah, I think so.
Okay.
This is a great. this is really a great article. I read the article a couple of times today, and I'm really impressed with the insight of the authors of this particular article.
And I only sampled some of their examples. They had many more examples of patients being transferred to their particular facility, which was a high acuity facility.
Tertiary.
Yeah, and they talked about just delays in treatment, from being suspected COVID, not COVID, people being afraid, all of those sorts of things. And we've talked about this before. There was a tunnel vision that occurred for a period of time, and that's kind of all people could see was it's COVID or it's not COVID, and not really seeing the possibility of other things.
I'm starting to see it happening again, though.
Yeah, we're going to get into that, and let's go ahead and get into, and John, if you don't mind deferring any discussion, we'll wait till the end and just get through this little bit of a presentation I have.
Okay.
Okay, so our topic is going to be COVID-19 pandemic impact on cardiovascular surgery. Okay, I thought this quote was really great. It's from an article I'm going to reference that's not really about cardiac surgery, but I think it had some interesting insight into what we're going through with the pandemic. this article, and I'll show you the entire article, but it's written by Hurmovic. I hope I'm saying that correctly.
I think so.
Intermittent outbreaks of infectious disease have had profound and lasting effects on societies throughout history.
Now, this was written before this
This was
pandemic.
actually, this is the article. It was written in May 2019 in the Psychiatry of Pandemics. Okay, they were looking at social, economic changes that occurred through pandemics through history. So our current pandemic hadn't even occurred yet, but it's got some really insightful information. So just a brief summary of the major epidemic and pandemic outbreaks. Smallpox is likely predated recorded history, all the way through 1977. There was evidence of some mummies that were examined in Egypt. I think Ramses V looked like possibly had pox on his mummified body. So they think that one's been around pretty much since the beginning.
And we've wiped it out.
And we've wiped it out.
But it exists in a lab.
It does. And you know why they kept that?
Yes.
Just in case something happens again and we need to study it, right?
Yeah.
So I don't think it was until 1980 that the World Health Organization actually declared it eradicated, but the last known natural infection was in 1977. I did read there was an accident in a lab in, I believe, 1978 where there was an infection that way, but it hasn't been out in the world for infecting since 1977.
Kind of like SARS-CoV-2, an accident in a lab.
All right. Yeah, so then we've also got, I'll just run through these real quick because they're kind of interesting. The Athenian plague, and you have to remember too, in earlier times, anything that was unexplained illness was called a plague. The biblical references to plagues, so pretty much any disease. Although we'll talk about a little bit later about what is actually the plague. But they called this the Athenian plague. It was in 430 through 26 BC. It's not known exactly what it was, but it was possibly typhoid fever or Ebola.
Ugh.
Then we had the Antonine plague of 165, 180 AD. That was likely smallpox. Then the Justinian plague, which was actually the first real plague, because the plague is used to describe the bubonic plague. And although they didn't know exactly what this was at that time, this was the first real outbreak that was recorded of that particular disease. And it was 541 through 750. And I have some interesting things about, let me see if I can find it real quick. So the Athenian plague, 25% of the population died. Social changes.
Of the world?
Of where it affected.
Where it affected.
It was in Athens.
Okay.
But, that was a very center of the universe kind of
At that
thing back
time.
then. But some interesting things that they noticed that happened, because people were so distraught and desperate during that time, social changes occurred. People became indifferent to laws that were set forth by men or gods. And so almost like they just started just living for pleasures, if you will. Then in the Antonian plague, it weakened their military, the economy, and then they actually saw a renewed spirituality, which facilitated religions to really take root and grow, specifically Christianity, which would then eventually lead to the fall of the Roman Empire. So, these have some lasting changes. Let's see, I talked about the Justinian plague was the first real plague. Okay, then we get to the Black Death. We skip ahead a little bit. And the Black Death, of course, is the bubonic plague as well. It's major outbreak, although there have been outbreaks many other times before and after, but the major one was 1346 through 1353. And it had some real lasting effects of better conditions for the poor because so many people died. Then the people that were left to do the work could demand better conditions, could demand more money. And it also started getting people to think about modern concepts of public health. Sanitation, quarantining became a thing. They figured out that, you know, sailors coming in to do trade, when they arrived in port, if they would make them stay on their ship a certain amount of time, I think it started out 30 days and maybe went to 45 days, and they did not get sick, then they could feel safe that they weren't infected and then could allow them to come into their city.
Interesting.
Yeah, so it's pretty neat. And even the really early ideas of social distancing, because later on in the 17th century, I believe, there'd be another outbreak of the plague, and I think we've all seen this, and I actually have an image of this I'll show a bit later, of the plague doctor mask. You know, it has that big beak in it.
Yes.
And that actually can be considered a form of social distancing, because even just the outfit that they were wearing and the beak required them to be a certain distance back. Now, that's not why they thought that that was a good idea. They actually believed in the miasma theory. Do you know about that?
No.
Okay, so that was the idea, because of course medical innovation and technology hadn't really figured out why some of these diseases happen. You know, early on people thought if they were religious, they related it to men being sinful and being punished from gods. But later on they decided that it could also be that, but the way that they thought it spread was through air, through foul smells. So the beak was actually a place where they could put aromatic herbs so that the air that they were breathing when they were taking care of these sick patients who smelled, because they had all these, you know, pustules, it would diffuse the diseased air and keep them from getting sick.
Ah,
Yeah.
okay.
Yeah, pretty clever.
That was pretty clever,
Yeah.
actually.
Okay, and then
And what is the theory called?
miasma, M-I-A-S-M-A theory.
Oh,
Yeah.
That's pretty interesting.
Okay, then after that we had the next major one were the cholera plagues, and you can see that there have been 7, and we are currently in one right now. And they occur, you know, where they're not occurring here for us, but they occurred at all different parts of the world. Then, of course, the first major one in the 20th century occurred in the Spanish flu, and that was 1918 to 1920, which, of course, it was the H1N1 flu strain.
Now, why is it okay for them to call it the Spanish flu? We can't call it the China virus.
Well, there's a reason for that. I actually read about that. Because the first reported case occurred in Spain, although, and at the time, that's just what they called it. They hadn't, you know, I guess, devised.
They weren't so socially
woke,
so
advanced yet to start calling it the H1N1. But they did determine later that it was an inaccurate description, because there were other places that it likely infected people were before that one. That was just the first known one.
Ah,
yeah.
Okay, fair enough.
But the Spanish flu, it pushed for a lot of different changes. It improved patient care. It started U.S. public health restructuring with preventative medicine, employer insurance plans, overall expanding of health care to general population. So pandemics can be very powerful change innovators.
I'm surprised yellow fever didn't make the list.
Well, and I considered that, but because the main information that I could find about yellow fever, and he didn't discuss yellow fever in this particular article that I was reading, but I did do a little additional research. When it broke out in Philadelphia, it did influence our founding fathers a lot, but as far as for social change worldwide, I didn't have a lot of information on that, so I just kind of moved over that. And of course, there are other epidemics that have occurred.
Sure.
These are just some of the major ones. Then we had the Asian flu in 1957, 1958, then the influenza A pandemic in 1968, the HIV pandemic, 1980s until, you know, whenever. People live with it.
You live better. Actually, you can live. There are some people, healthcare providers that I know, that would rather get infected at work with HIV than hepatitis.
Because the treatments are
so good.
Yeah, well, they didn't used to be.
No.
No.
It was the death sentence.
And then SARS in 2003, swine flu pandemic in 2009, Ebola 2014, Zika in 2015, which Zika is unique in that it was the first major epidemic that the information was shared on social media, and it really drove the public being informed about it, because that's how people were sharing.
What Zika does is so bizarre.
Really
how
is.
it causes that microcephaly in the
infants.
fetus, if you happen to get pregnant and in some period of time during that pregnancy, I guess there's probably a specific unit of time, get infected with Zika, then your baby develops with this microcephaly. It's a horrible thing. I mean, it's just amazing.
It's really horrible.
It's bizarre.
It's very strange. And then, of course, our current pandemic, which was not included in the article because it hadn't happened yet.
Yes.
COVID-19. All right, so here's that picture that I think a lot of us are familiar with of the plague doctor. And there's that beak, and it is stuffed with the herbs. They thought it would protect them.
Interesting.
Yeah. Okay, so cardiac surgery, can it wait? That's kind of what we were wanting to discuss here. So let's see. This is an article that I found that was actually published in the Annals of Thoracic Surgery, but it was on behalf of the Society of Thoracic Surgeons, COVID-19 task force, and they also worked with a similar task force in Canada to come up with these guidelines. This was published originally April 16, 2020, and then I think online, and then maybe in print August 1st, 2020, I think is what I found, and it's by Haft and Associates. All right, so here was the graphic that they were to share in trying to help manage how are we going to manage our cardiac surgeries in patients during this time. And remember, this is pretty early on, so this is right after the pandemic was really starting to pick up speed. First off, the first principle was to protect the cardiac patient. So if we didn't have our patients in the hospital, we're protecting them in that way. They're going to do stage triages, which we'll get to that. I actually have those detailed out. Then protecting the institution and the society, because we're going to save the resources, and this is kind of what our editorial author talked about, for the pandemic resources. Everything from blood to PPE to hospital beds to ventilators, all of the things we're saving for this crisis that we're in. Third principle is to protect the healthcare teams. So utilizing, and we know this doesn't exactly happen, but utilizing the appropriate people to take care of these pandemic type patients and reserving your cardiac teams so that they don't become sick or overworked so that they can do the surgeries that have to be done. But I don't think that necessarily happened. I think a lot of people got moved around and put where they had to go. Okay, so here's in detail the principle one. So protecting the cardiac patient. As the hospitals become increasingly populated with the patients, confirmed or suspected of COVID-19, exposing those cardiac patients will provincially increase their risk of a hospital-acquired infection, and it's uncertain how the acquisition of COVID would impact the morbidity and mortality. So that makes sense, of course. Principle two, protecting the institution and, I got to click. There we go. Institution and society at large. So if we reduce the number of cardiac surgical procedures, it'll result in reserving the resources, saving the ICU beds, the ventilators, the circuits of ECMO, right? Mm-hmm. Drugs, the PPE, and just healthcare workers with advanced skills that may need to be used. Principle three, protecting the healthcare team. And they talk about, that cardiac surgery has those people have a special skill set, and that we need to be able to keep them available for the potentially non-essential operations. So we don't want to increase their chance to getting COVID-19, I think is the point of that. So we can save them for those urgent cardiac procedures that have to occur. Okay, so here are the triage way that you're going to triage your patients. So table one is for the least amount. So maybe in the early stages, or maybe once we had flattened the curve, if you will. It's for triaging during Tier 1, which is 0 to 30% of the inpatients are COVID-19. And you'll see that it's broken up into a couple categories. So you have your essential services, all the things that you should be able to do. And then to the right would be the deferred, the things that you should go ahead and put pause on. So you can see during this period, you can do all inpatients, you can do pretty much any kinds of surgeries that you need to do. Outpatients, if they're at a huge risk, but asymptomatic patients, we're going to push pause. Anything that could have another kind of intervention, also push pause on that. And then they give some points at the bottom, kind of guidelines to help you do this. Programs are encouraged to adopt a mechanism by which patients can be screened in order to identify if they have increasing symptoms or not. So they want you to monitor the patients because, of course, they know there's some risk there. The patients that are always the sickest don't necessarily present that way and need to be monitored. Do any kind of transcatheter interventions, alternate percutaneous therapies, and following the organ transplant guidance by the Organ Sharing Network. Okay, this would be Tier 2. So this is 30 to 60% of your inpatient are COVID-19. And you can see the essential services have shrunk, right? So it's just inpatients and outpatients that have progressive symptoms and any asymptomatic CAD but very impaired systolic function. Deferred would be any asymptomatic patients, outpatients, any ones that you think reasonably
you can delay safely.
Safely, yes, exactly. And the guidelines are pretty much the same. Okay, so now we're getting up there. This is for Tier 3. This is 60 to 80% of the inpatients are COVID-19. And you can see that all inpatients who cannot be discharged safely, they're going to get their surgery. But if you're inpatient and they think you can go home, you're going home. And then anybody who would deferred, I thought this was interesting. Patients deteriorating while waiting would need to meet the criteria for admission before consideration of surgery. So just being at home and not getting better, you would still have to meet the essential criteria, if that makes sense. Okay, and then the last one, they've named it Stage 4. So greater than 80% of your inpatients are COVID-19. Oh, I didn't click it. There we go, thanks. Only emergency services, and only if the resources are available, and deferred all inpatients, judged to be stable and capable of waiting, and all outpatients. Mm-hmm. All right, so let's talk about kind of where we are now, the next surge, how will cardiac surgery be impacted? And I'm almost done. I'm going to show a couple graphics here. This was as of yesterday. This is Johns Hopkins University Center for System Sciences and Engineering COVID-19 dashboard map. These are the cumulative cases across the world as of yesterday. And you can see, I mean, us in particular, we've been completely inundated. There's just pretty much nowhere.
Well, Europe.
Europe too, and South America and Mexico and Central America, all of those places.
India?
Yep. Okay, so this is according to Johns Hopkins. These are the numbers that were as of yesterday. So we've got over 56 million confirmed cases, over 1 million, 1.3 million deaths. In the U.S., 11 million confirmed cases and 250,000 deaths.
What is that? Let me.
The percentage? I didn't calculate that.
I'm going to do that.
Okay.
What was it? 250,000 and 11 million?
Yeah, a little, like almost 11.5 million, not
Okay.
quite. All right, that's it. That's all I got. We're ready for our discussion.
2% mortality.
2% mortality. Here.
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 In the United States, yes.
Yes.
So, John, how about if we bring you in, since you've patiently been waiting there in beautiful Orlando, Florida, and you can kick this off with some discussions.
Yeah. Tammy, what you were just, well, a couple things, Joe, thank you for that. Tammy, when you were just talking about the stages 1, 2, or tiers 1, 2, 3, and 4, and you were saying the 0 to 30% and 30 to 60, you're talking about the inpatient percentage of a hospital being 30% or 60%. I mean, the highest inpatient percentage hospital has been way below even tier 1. I mean, our entire hospital is, a fraction of a percent is a COVID patient. So I'm not sure if you could clarify that.
Well, I think these guidelines, again, remember, they were set out by STS in the beginning. We didn't know
STS?
Yeah.
Society for Surgery.
Yeah. We didn't know how this pandemic was going to play out, right? Mm-hmm. So these are the guidelines. This is the framework that they had put out there for practitioners, for surgeons, for hospitals, and hospital administrators for some guidance. Mm-hmm. And what I think is interesting, the point that you bring up is that we didn't get to the upper tiers, and we definitely didn't get to stage 4, thank goodness. But I think we can speak probably pretty representative of most practices. Cardiac surgery still stopped.
It did.
So I think that's an interesting thing. They gave a framework to follow. However, even though we weren't to those types of levels, it stopped.
But I think so much of this depends on where you were. So, John, your experience in Orlando, I think, was different than our experience here in Houston.
Oh, you think so?
I do, and let me see if I'm right, if I remember correctly. I think you told me they didn't slow down surgery at all.
No, we had about 2 months where it was almost screeching halt.
Oh, really? So I was
just
wrong.
like
But the administration at some point was quick to open it up, and it's just now getting back where it's very busy, I would say, these last 2 weeks. Mm-hmm. But yeah, we hit the skids pretty hard. And as your paper points out, Tammy, I think what's emerging, Tammy and Joe, here is something we kind of maybe suspected in the beginning, but now it's coming to reality. There's a second tragedy besides COVID. There's a second tragedy which may be even equal or close to the tragedy of COVID. And there are the fear that's been generated. Yes. And I'm not going to place blame, but let's just say the fear that has been instilled in our society, largely through the media, largely through confusion, largely through a political football, has been so outrageous that people are willing to die of another disease at home than risk coming into the hospital and dying and possibly catching and dying of this horrific kraken monster called COVID-19. This is what's been instilled and was instilled in our society. And the evidence of this paper actually cites multiple studies that found a 45% decrease in people willing to even come into the hospital, even though, I mean, you've heard the saying, it's as serious as a heart attack. Heart condition is as serious as it gets.
It's the number
maybe with
one
the exception
killer.
of a massive stroke.
Mm-hmm.
It's the number one killer of us in American society.
And
number one has been for many years.
So it's not just hospitals were stopping surgeries. I don't mean to say that. It was just like John points out.
Surgery centers and.
Well, I was going to say it's also patients choosing not to seek treatment.
Yes.
And so we have twofold thing going on there. Hospitals trying to prepare for the unknown, not sure about resources. We're not sure, what's going to happen to these sick patients that are going to come in if they happen to contract, COVID in the hospital.
Mm-hmm.
How that's going to impact their, mortality, morbidities, but also people just choosing not to go. We have a personal story of someone who...
A very, very personal story.
Yeah.
And John, you know what? This is a really good one. John, I'm going to ask you a question. Yeah. You're doing a triage. You're on the phone. And somebody calls you up and says...
Well, tell them when it is. I think it's like, what, May? May of this year?
Yeah, it was in the height of the pandemic.
It was in the height. We were on,
Our first surge, right? Mm-hmm. Our first surge of cases. So the patient felt really bad. They had a fever. they were short of breath, they were diaphoretic, and they just felt really bad.
Something,
yeah.
50s, late 50s,
Yeah.
I think.
Yeah, mid-50s, late 50s, you know, otherwise relatively healthy individual.
Healthy.
Yeah. What are you gonna think it is?
Well, I think they need to come to the ER and get a
yeah, that's really good.
Checked.
but if you have COVID mania, if you are listening to what has been in my view, disinformation campaign and fomenting of fear in our society about something, which I'm not saying the virus is a good virus.
It's bad.
It's not good for us, right?
Right.
It will make you sick and it will kill some people. You know, and it's probably a little higher than what influenza will do. And I think it has a higher level of lethality than influenza does. But of course, we've also learned how to manage influenza a lot better. It's been around a lot longer than this has been. This was very novel, right? And so anyway, but you could see where in that environment, somebody would say, oh, it sounds like you have COVID. If your symptoms get any worse, then you know, you need to reach back out to us. And of course, the patient was also very fearful of coming to the hospital. So you had two things happening at one time. A hospital not wanting everybody to come to the ER because they had COVID, if they truly didn't need hospitalization, and no one knew because everybody was confused about what was happening, and a patient who has these symptoms that believes it's COVID anyway himself, so he's not going to the hospital
and then
because
he gets confirmation
really doesn't
from
want
the
to.
hospital
Yes.
that it's probably
It's
COVID.
probably COVID. I'm going to be okay. I'll get through this. I'll make it. Finally does come to the emergency room, is taken to the operating room for initiation of VV ECMO to support his COVID-related ARDS. Although it's not, I know it's not truly ARDS, but that's what I call it. COVID-related ARDS, or COVID-associated lung failure, whatever you want to call it. And somebody decided to do an echo. And they saw all this fluid, like a pericardial effusion. And they're like, well, what's going on here? I mean, is this another symptom of COVID, or another thing that happens? You know, besides the potential hypercoagulability, you get a pericardial effusion. Maybe it was causing a massive myocarditis, whatever it might have been. And so the surgeon does a little window. And as soon as he cuts into the pericardium, out gushes blood. So all of those symptoms, fever, shortness of breath, diaphoresis, feeling really bad, are also symptoms of a heart attack. And he had ruptured his ventricle. So he had a big RV infarct, blew out his ventricle, had a pericard, you know, obviously had blood in his pericardium, was resuscitated. We ended up putting him on VA ECMO and sending him, you know, for a, for higher level of intervention, because at that point in time, he's going to need a permanent VAD, or he's going to need a transplant, or he's going to need a total artificial heart. He's going to need something more than we're able to do. And, you know, at some point in time, he succumbed to the issue. But again, it delayed treatment. And how many of these have happened?
Even so much as I helped take care of that patient in the ICU.
Yes.
And I don't know how many COVID tests were sent afterwards, but they were still convinced he's got COVID.
Right.
We're on VA ECMO. All of this has happened, and we're sending multiple tests over and over.
Yes. And then talking about the tests, when you showed the statistics about the confirmed cases, you know, that's dubious, because you just had Elon Musk reported in the news, same nurse, same machine, same time frame, 4 tests, 2 were positive, 2 were negative. So he had 4 tests with a 50% chance of it being negative or positive, and doesn't really know whether it's negative or positive, because how are you going to know? So what does a confirmed test really mean? You know, I'm not sure about that. So, you know, if the collateral damage from this, I think this is the point, the collateral damage of this has been just horrific. And, you know, I'm not trying to make this a political commentary, but I can't really understand. I can't understand it other than that, because this closing of the schools. I just watched the news conference today from the task force, the COVID-19 task force, and they had a speaker on there, Eleanor McCants-Katz, and she is the Assistant Secretary for Mental Health and Substance Abuse, and she is reporting huge numbers of despair, depression, suicides, alcoholism, drug abuse, physical familial abuse. It's a big problem. John, I'm sorry.
I saw a bona fide report, it was about 3 days ago on the news, that said phone calls to the suicide hotline are up 800%.
I read
now,
that.
that's a fact. That's the suicide hotline incoming calls. Okay, now that's also true. I don't know if it's 800%. I don't know the number. Alcoholism, depression, drug use, spousal abuse, child abuse, loneliness, mental health is all multiple higher. I don't know the numbers, but I can tell you that the suicide hotline from a year ago today is 800% higher number of calls that they are taking. So when you combine another aspect you guys are hitting on, the misdiagnosis in our medical system, I would wonder if it's ever been worse, if it's ever been higher. You probably have to go back in 100 years when we didn't even know how to diagnose things to get a higher misdiagnosis than what's occurred here. Everybody has tunnel vision, or not everybody. A large percentage of people have tunnel vision.
Right.
That we're going to keep jamming this square peg in a round hole called COVID until it fits.
Yeah.
Okay, and so I know people who, we have a patient on ECMO, Joe and Tammy, that came to the hospital with every single COVID symptom. ARDS, every single COVID system, now has been on ECMO for quite a number of weeks, has permanent lung damage, irreparable, may have to be up for, considering now for a lung transplant. Never once has tested positive for COVID. Never once. Has been tested, I don't know how many times. We still don't know what this person has or had. Don't know.
And it might have just been, and that's, I think, the problem is, we don't know that, there could be some other, disease this patient had, inflammatory disease, just an autonomous inflammatory disease, that they developed pulmonary fibrosis, ARDS, and pulmonary fibrosis from whatever that inflammatory disease state was. But what brings into question for me is when I look at the numbers, certainly I look at the total number of confirmed cases. I'm not sure I understand what that means, and I don't think that is reliable data. It's not like a call center. You can count them.
Right.
We're depending on the test to be accurate. So is the number actually more than that? Is the number actually less than that? And then watching time and time again, and it's happened in our hospital too. We have had patients on ECMO. I was going down to another area, without mentioning any places, where we were managing 16 ECMO patients in one unit at one time, and it didn't matter that the COVID test was negative. It was still listed as COVID. So how many of these are something else, and they've been put into that arm, and they're being then calculated to give us a true lethality of the coronavirus? I don't think we know. Is it really more like 0.2 or 3% like influenza, or 0.1% like influenza, or is it actually 2%? And then who is vulnerable to
because that I think
dying
was
from this?
A little surprising. Of course, you think people who are immunocompromised and the older population, but that wasn't really who we saw a lot of going to what I would think the highest level of support you can get for COVID would be ECMO. Those weren't really our patients.
No, and that's yet another. That's yet another peculiar conundrum. Is throwing everybody on ECMO. I was contacted, I think I mentioned this in one of the other programs, I'm not sure you were here, but I was contacted by a fella who was trying to retrofit, modify a standard dialysis machine into an ECMO pump that he already had approval that if you build it, we will let you put it on the market and sell it.
Oh, no kidding.
And so I wonder how much trash technology and people who have essentially profiteered from this thing we're going to have to deal with for years to come.
And that's not new. During pandemics, through this, history article that I read, anytime there's some kind of pandemic, epidemic, something like that, the quacks come out, if you will, selling, especially earlier times, selling all kinds of potions and things that
snake oil.
Not proven to work, but people are so desperate for something to be the thing that's going to fix it. That guy is so desperate to profit from the situation. He knows there's a lack of resources. There's a lack of probably technicians. I mean, before you know it, maybe you don't even have to be trained to be an ECMO technician. I mean, you know what I'm saying? Like, it just keeps going and going and going.
Absolutely. And then, well, what about those people that took the chloroquine for the fish tank because hydroxychloroquine was considered, and they saw chloroquine and they just forgot the hydroxy part and took it and it killed them both.
Yeah, they're both dead.
It killed their kidneys, put them into renal failure and killed them. It was poison, for humans to consume it. I mean, it's crazy what people have done through this. And
let me ask you guys this. Tammy, you listed a whole bunch of the history of pandemics. Has there ever been a pandemic where they closed the schools to children going to school prior to this one?
Well, a little bit. There's been some, but the only thing that I found, and again, I didn't do an exhaustive search, but actually in this article, I think it was, I didn't list this because it was so specialized, but it is actually an answer to your question. Let me find it.
Well, while you're looking that up, Eleanor McCants today said that the worst thing we've done was closing the schools. K through 12 should have never been closed. And she is the director. I mean, this is the mental health and substance abuse department is brand new, and
this is a government agency.
It's a government agency, but it's relatively new. It hasn't been around for years and years. And she's I think the first assistant secretary for mental health and substance use. But she said the schools K through 12 should never have been closed, never. And And what's the other guy's name? Gerard, I think it was Gerard. He was saying afterwards that that when they do the contact tracing, the kids who, when there was an outbreak in the school, because kids would test positive, they found out that they didn't get it from the school.
Right.
They got it from home. And they weren't even going to school and transmitting it. They were getting it, so they just...
Well, and that goes into, what is that example I told you earlier, just the disruption in learning. You know, right now, I don't know how it is for you, John, but the school systems here, if your child has a close contact, you know, they're not even showing symptoms, just they were in close contact with
2 weeks.
Yeah, 2 weeks at home immediately. So I have a friend whose son, this is his third close contact. We're only in the month of November, so he's already spent 6 weeks at home and he's never been sick once.
Yeah, it's craziness. And what impact is that going to have?
Right, and he has, I think, some learning challenges, so that's really hard to go from you need to be in school, that's how he learns, to now you have to do your work at home for 2 weeks and you weren't even sick.
Absolutely. Would you you guys keep talking, but would you excuse me for 5 minutes?
Of course.
I'll be right back.
Okay, John, I have an sort of answer to your question. So there was a documented little blurb in here about in 1972, former Yugoslavia had an outbreak of smallpox, and it wasn't even a huge outbreak, but they took that so seriously. You know, that was a socialist country. They declared martial law introduced mandatory revaccinations. Entire villages, neighbors were all quarantined off. You were not allowed to leave. Entire geographic regions were sealed off. 10,000 individuals who may have come into contact with the infected were placed in actual quarantine. Borders were closed. Non-essential travel was suspended. But because it's the kind of country that can just take away all your freedoms, within 2 weeks, the entire population of Yugoslavia was revaccinated, which is about 18 million people. During that outbreak, there was only 175 cases identified and only 35 people died. Now, they view this as a success. You know, it was prompt and massive response, so it eradicated it from the society before it got out of control. But I think that that goes to your point of, yes, other places have done this, but I don't think it's been done on this kind of scale.
Well, there's a lot to unpack with what you just said there. So this has only been done in a very strict and authoritarian socialistic society. It's never been done, which probably went too extreme on that. You could probably call it something else.
Yeah.
But it's never been done, and that was the only time that someone went that extreme and did something to that extreme, and it actually worked. But you're saying they combined it with 17 million vaccines or something.
18
the
million.
entire country was able to get vaccinated
Yeah.
in approximately a 2 or 3 week period. And then so it wasn't just a single prong maneuver of closing the schools.
No.
It was, we're going to do A, B, C, D, E, and F. No one's coming in or out. Everyone's getting vaccinated. We're going to see this quiet down, and then we can reopen up. So
well, and yeah, so if you look at it that way, they were very extreme in their methods, but it was a limited time period. So I guess in that respect, their society got back on with the business of being a society in about 2 weeks. This event was considered so successful and useful for working out scenarios that it's now what's called the, dark winter response. If we had a highly contagious disease, either natural or an act of bioterrorism, this is what is the model that they think will be successful. So it's pretty interesting.
Let's hope we don't have that.
Yeah.
Or that this isn't that. But let me ask you this, and I'm doing this all off of my own anecdotal observations.
Okay.
There have been several healthcare workers, whom I know, that have gotten COVID-19. Now, none that have been confirmed to have come from the hospital. Notwithstanding, I know there have been some healthcare workers who have actually died in certain areas of the country. I think New York was a place where that happened. However, there's certainly, given how many healthcare workers exist in any one hospital and the need, the requirement really to move these patients, go back and forth, even with all of the precautions that we take, it certainly is not perfect and never is going to be. But we don't see mass outbreaks in the hospital, and proportionally, the number of healthcare workers who are actually caring for these patients that have either gotten sick from it and, more importantly, have succumbed to the disease is, in my view, surprisingly low.
It is.
And, I don't, that N95 mask, really, it's better than a regular cloth mask, certainly, but they're not perfect. They don't fit perfectly.
You know how N95 gets its name?
How?
It's only 95% effective.
Right.
That's how it gets its name.
Yeah.
I got it. Well, and just me personally, I'm in between sizes. So I wear the one that's too small, or I wear the one that's slightly too big. What are you going to do?
Yeah. Gain weight.
So guys, can I throw another thing about? So Joe, you've been to our institution. It's extremely large, right?
Huge.
I mean, and let me ask you guys, at the institutions you're at, do you have the people when you walk in the entrance taking your temperature with the laser gun?
Of course.
Well,
And the numbers that they read to you are 96.7, 97.3, right? But basically, every day I come in and they read them out loud. I had about 8 people in front of me in line about 3 or 4 days ago, and the woman doing it, very nice lady. She's been doing it almost the entire time somehow. But anyway, she 96.7, 96.7, 96.7. 8 people in a row, all were 96.7.
well,
Now, the highest that I've ever been is 97.3, like once or twice. I'm not sure how that happened. But what are they taking a temperature of? Is this your skin temperature? What is this temperature?
it has to be. I've wondered that
Well,
myself.
of course it's your skin temperature.
And one day I was.
So it's a laser. It's a laser
Okay,
light.
so what is considered
Reflects
a fever
back.
with this device?
What's considered what?
A fever. What number says, oh, you have a fever?
Well,
what is it?
I can-
99? I mean,
I got one day I had been rushing between facilities, and I mean I guess I was just busy that day, and I went to my last facility. I was there to pick up some supplies, and got my temperature read, and it was 99.0, and that's why I think that they're alerted to lower numbers, because immediately I got the extra questions, not all the normal things. And
But you could have been also out from outside in the sun.
well, and that's exactly
There's a
what I
lot of-
said. I said, this is the 3rd place I've been for the car, and
Give it a break. Yeah, just wait a minute. It'll
yeah,
come back down.
and then they were fine. But you would think that it was like 101. So I think they might be attuned to that it's going to be a lower number, if you will. But a lot of our facilities now have the automated ones that read you when you're walking in. There's not even a person there. But what I want to know is, it doesn't tell you your temperature, just like alarm sound or something if you're out of range. Do people come out of, like?
I don't know. It might be a straitjacket. I don't know. I really don't know what they do. I don't know. I'm sure they do come out. I'm sure it alerts somebody. It must make something like says stop, or
I mean, I
please
guess.
do
I
not
haven't
go
seen
in-
it yet.
Don't go any further.
Yeah.
I really don't know. But how much of that screening is really useful? I know somebody who had a fever for a known other reason. It was some kind of infection, staph infection of some sort that they were managing with antibiotics. So they had a definitive diagnosis, and they were febrile. They took some Motrin, and they put some of the hand sanitizer gel on their hand, rubbed it on their forehead and their ears, and when they walked up and got their temperature taken, it was perfectly normal. But yet they had a fever, and they were essential. They knew they had to go to work. They had to be there to take care of these patients. And so they were like, if I go in there and they sense a high temperature, I'm going to basically not be going to work. And that's going to deplete the resources, the human assets of healthcare professionals being able to take care of these patients.
Yeah.
That's the
are you
decisions people are making.
guys aware of, have heard of any employee at any of your hospitals getting their temperature taken and being sent home because it was too high, not being allowed to go to work? Have you ever heard of that?
Yes.
I have.
You have?
You have.
Yes. I know of
Because
it happening.
in July,
I know of one.
I asked
I know of it
the
happening
temperature-
one time from somebody that I know personally.
I asked the temperature taker at our hospital, which we probably have in two 12-hour shifts, 7,000 employees a day would be my guess. Right, Joe? At least, right? You've been there. And I
Yes.
asked the temperature taker one day, and this goes back a few months ago, but COVID had been roaring hard for 5 or 6 months. Has anybody ever been sent home for too high of a temperature? She told me no. We've never sent anybody home. I
Right.
said, what happens if you get too high of a temperature? They make you stand under the air conditioner vent for a few minutes, and you come back and your temperature's low and you get to
Oh,
go to work.
actually, that happened to me once in the beginning. I forgot. I had come in from outside, and I didn't feel warm, but I guess I showed a little
Sure.
warm. And she said, you look red in the face. Why don't you stand in front of the fan for a minute, and then I'll take your temperature again in a minute.
Right. Right. Exactly. I think my point, though, kind of circling back, if I may, because we kind of got a little sidetracked on
us.
on something totally different, is, and this is just again my experience. and I'd like to know yours, John, I'd really like to know yours, anybody else out there, is I just don't see the healthcare professionals that I work with that are in direct contact with these patients that are in these big units coming down with this disease. So the transmissibility and the infection rate seems so much lower there with confirmed cases than it does in a bar.
Well, yeah, but don't you
and
think...
it just seems odd.
I think some of that's going to have to do with most of the healthcare providers that would be taking care of these patients are used to having patients that, you know, might be contagious in some way. And so the precautions to them are familiar and they take them seriously, don't you think?
I do, but I also think that of the healthcare professionals that have, let's say, acquired COVID-19, very, very few. Look, the infection rate in the hospital is really low. Mm-hmm. I don't know what it is, and I'm be interested to see that data. Maybe we should do a program on that. You know, a follow up to this, because it's very worrying.
You mean
to
patients
me.
that come in, don't have it, and get it? Is that what you
Or
mean?
healthcare professionals in the hospital getting it, given the number of patients who are in these hospitals, people coming in and out of these hospitals, it's huge. And yet you don't see the infection rate very high. And those that get it, we don't see the same mortality associated with it.
Yeah.
And I just wonder, because of course early on, remember that doctor
Yes.
who was the what do they call that? Not the bell ringer, when somebody's...
Whistleblower?
The whistleblower, yeah. Thank you.
She did the story on the news in New York?
No, the one in China.
Oh, her, yes.
Him.
Yes.
It was,
yeah,
it was a guy
him, yeah.
who had identified this virus and was trying to get the word out and ended up supposedly dying of COVID-19. Now, did he really die of COVID-19 or something else? I don't know.
Well, we had that doctor that, I'm sorry, I can't remember her name. She was one of the ER critical care doctors in New York, and there was, you know, a news feature, and she was interviewed, and they followed her around. And, you know, it was when we were getting the conditions, what it was like there. They were so overwhelmed. And just a month later, she got infected and died. Weird.
Well, that is, but again, you know, that's a case.
Yeah.
And I think that gets sensationalized to some degree. It's not good. I feel bad that happened to her. But, of course, it makes me wonder, did she really die of COVID-19? And how is she so vulnerable, yet how many other people came in contact with that very same patient? And so it's that's the part of this that sort of leaves me with some question marks as to, I don't think we know what the hell's going on.
Yeah.
At the end of the day, I think we've solved nothing, because I think at the end, we just don't know.
We don't know.
Yeah. It's well, unfortunately, the mysterious aspect of this this disease, this virus, has only thrown fuel on the fire of the fearmongers and the mysterious, monster makers of this, because, you know, and maybe maybe a lot of it isn't even true, or maybe it is, but one day we'll find out. But I was going to say also, Joe, that you're absolutely right. In my experience, the amount of healthcare workers that I know, in fact, all of the healthcare workers in my circle that have gotten it, it was attributed to getting it somewhere other than the hospital. They got it from their wife, they got it from their husband, they got it from a friend. It was never once that I know of. I don't know a lot. I know about 8 or 9 that got it, and it was never attributed to exposure from a patient. Now, hopefully, that's a testament to our PPE. I'm hoping, that's what it is. But it sure is a microscopic number, it seems, the number of healthcare workers. And these people spend, the 12-hour shift nurses are a lot of times locked in the room for 12 hours.
Yeah.
With these patients, especially in the early days. Now I think they come in and out a lot more.
And they're not all wearing pepper suits.
No, they're not wearing pepper suits.
In the early days we did.
Yeah. Oh, remember
and
those?
That was, yes.
That was
screaming like a madman because you couldn't hear.
Well, and
Then you take
sweating like crazy.
And then you take the suit off and you keep yelling. Everybody's like, I could hear you, I could hear you. But anyway.
Well, if I could, if
please.
y'all are finished with
No,
I was
we
just
have
going to
yes.
sum up something from this History of Pandemics article I thought was a nice way to end it. We talked about how pandemic outbreaks and other epidemic outbreaks really pushed for different changes, some good, some bad. But this particular quote I thought was interesting. Pandemic outbreaks have decimated societies, determined outcomes of wars, wiped out entire populations, but also, paradoxically, cleared the way for innovations and advances in science, including medicine and public health, altered economies, and political systems. So I think the true effects of the pandemic we're in, we're not going to be able to see for quite some time. Not just, the medical treatment portion and the mortality and morbidity and all of these things that everyone's talking about, the long-term effects of having COVID and surviving, but I think the long-term effects of how it's going to affect our society. Companies a lot of companies are not going back to offices. They're staying at home. Are we going to have more isolated type communities?
Mm-hmm.
That happened in one of the earlier epidemics where it was Muslim communities, and because they saw when they all lived close together, the disease spread, and so therefore they moved out to less populated areas to keep themselves safe. But in turn, it had a huge effect on Islam being spread to lots of different countries and having this huge impact on changing the entire geography of the political systems and the religious systems and the cultural systems of those places. I think it's going to be
that's a very good point. Well, I'll give my final thoughts, then John, you can wrap it up if you don't mind. But I think that, as I said earlier, I feel like and I'm not trying to be political, but I do think the comment you made about changing political systems is very germane in this particular circumstance, and that there has been a fomentation of fear deliberately, which has, in my view, blurred the lines of what is actually science and how we have really basically come to understand this virus, treatments for this virus, vaccines for this virus, whatever the case may be, on down the road, from therapeutics to prevention. And I think at the end of the day, I'm not a conspiracy theorist, but I think you would have to suspend all reason to not recognize that we don't understand as much about this scientifically, because there has been so much political influence in this particular pandemic, and I find it troubling. So those are my final thoughts. John?
I think in the end of the day, now maybe this will be acute or maybe it'll be chronic, but I see three devastating, let's call them side effects of this pandemic. Number one, the financial economy and the financial system has gone an absolute catastrophic blow dealt to it. Like I said, let's see, maybe if we get all vaccinated, maybe it can rebound. So let's just see if it's acute or chronic. That's number one, the financial devastation. A lot of it's unreported, by the way. The number of small businesses and restaurants that are out of business permanently or just something like 1 out of 5, and more coming. Number one. Number two, the loss of freedoms that we are experiencing, and hopefully won't be everlasting. But as you know from history, once you lose freedom, you usually don't get that freedom back. So hopefully that'll be acute and not chronic, but I suspect it'll be the latter. And number three, the disruption to our personal lives, whether it's working from home, whether it's being paranoid to be socially active as far as groups are concerned, movie theaters, concerts, bars, large groups around the Thanksgiving table. Now you're hearing that one. Those three things stand out to me. There's 3 or 4 more I could list, like the the distrust of the information and the misinformation campaign, the political. We could list three of those. But let's just stick with those three: the disruption to our personal lives, the financial devastation. I think are just got a lot of us. The reason why we're talking about the side effects of the depression skyrocketing and drug abuse and alcohol abuse and all that. What are you guys' thoughts about that?
Yeah, absolutely, John. I couldn't agree with you more on all of that. Actually, I think we're all of like minds, and I hope that we will get to a point where we truly do understand this virus, and we get to a place scientifically to be able to manage it. I think the vaccine with both the Pfizer and the Gilead, is it? Moderna, having greater than 95% efficacy is huge and is going to be really good. They just need to get it distributed and get 300+ million doses, which is going to be a real challenge, I'm sure. But I
think they're estimating possibly by maybe next April or May that could be feasible, something like that.
I know they're targeting healthcare workers and our most vulnerable population first, which I think just does make sense.
Sure.
So, hopefully they can get that done. But our next program is going to be, and John, gosh, I hope you can be on this because this is so up in your wheelhouse. PerfWeb 49, Journal Club 11 is going to be December 7th. That's Pearl Harbor Day. And it is titled Veno-Venous Extracorporeal Membrane Oxygenation for Respiratory Failure. How long is too long?
Yeah.
And I think that's going to be an excellent presentation because, man, I'll tell you what, we're real good at putting them in, but we're not real good at taking them back out.
Yeah, once they're in, they're in.
It seems to be. Yeah. We've seen some real incredible case, but of course we've also seen I think this is why you'd be so good with this because you have some very long-term ECMO patients who actually did really well, but a lot don't. And so I think it's it's going to be a very good discussion. So we'll see you all December 7th. In the meantime, please, everyone, be safe. And thank you so much again for watching, for participating, and for your continued support. Reach out to us, and we will see you December 7th. Thank you all very much. And that's going to be in the morning, John. It's 9 a.m. to 10:20. Yeah. So that one's more for the European side of everything, which is in the evening for them. So we'll see you all then, December 7th. Thank you.
Thank you. Good night.
Great job, guys.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perceval, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EZ-Flow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. Easy flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. This is just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.